Welcome to Second Opinion, integrating novel approaches into the management of non-muscle invasive and muscle-invasive bladder cancer. This is medical oncologist Dr. Neil Love. On February 26 at the 2026 GU Cancer Symposium in San Francisco, we held a CME meeting moderated by Dr. Terence Friedlander from the Helen Diller Family Comprehensive Cancer Center in San Francisco, and faculty members Dr. Matt Galsky from the Tisch Cancer Institute in New York City, Dr. Andrea Necchi from the IRCCS San Raffaele Hospital in Milan, Italy, and Dr. Shilpa Gupta from the Tulsa Cancer Institute in Cleveland, Ohio. Included in the meeting were a series of pre-recorded video case presentations by Dr. Elizabeth Plimick from the Fox Chase Cancer Center in Philadelphia and Professor Thomas Powles from the Barts Cancer Institute in London, who met with me prior to the meeting. These cases were discussed by the faculty panel, beginning with Dr. Plimick. Adjuvant therapy of muscle-invasive urothelial bladder cancer took a major step forward at the October ESMO meeting when Professor Powles presented the IMvigor011 trial, and Dr. Plimick presented a patient she evaluated last year before the data were available.
She was 68 years old, T3N0 upper tract urothelial carcinoma resected, and based on the pathology, she was referred to a local medical oncologist who recommended adjuvant nivolumab. She sought a second opinion. So I'm curious, how would you have thought through this case? What would you have advised her?
So what actually did you discuss with her?
So we discussed the adjuvant nivolumab data with Checkmate 274. We did discuss the subgroup of upper tract urothelial carcinoma, which did not appear to benefit, as did the whole group as a whole. At the end of that conversation, she was hesitant to proceed. And so we discussed further using ctDNA to help make a decision. We ordered the Signatera test. Her CAT scan was clear and her ctDNA was negative. What would you have done in this situation? She decided to be observed without adjuvant treatment. We've had at least one follow-up scan and repeat ctDNA. Those are both negative as well. So far, so good. For this particular patient, I ordered ctDNA to try to inform our decision. Is that something you do in routine practice? I elected to use the Signatera assay, which is a tumor-informed ctDNA test. What test do you all use in your clinics in this situation?
Great. So this is a case of a 68-year-old woman with upper tract urothelial cancer. We've mostly been talking about muscle-invasive bladder cancer, who's now had the tumor removed and is considered high risk for relapse, but technically is disease-free. And so I know we didn't focus so much on the adjuvant nivolumab data, the Checkmate 274 data, but Dr. Gupta, how would you advise that patient? And do you agree with Dr. Plimick that there's not great data for the upper tract patients to get adjuvant nivolumab?
Yeah, I mean, adjuvant nivolumab is approved for both MIBC and upper tract disease, but if we do look at the subgroup analysis, the upper tract patients did not benefit, but that's also true for any adjuvant IO trial, both the IMvigor010 as well as the Ambassador trial. But I think we do have a valid option for this patient, adjuvant GemCis or GemCarbo, based on the POUT trial, and that's the only level 1 evidence to date in adjuvant upper tract. So I'm curious if Dr. Plimick discussed that or not, but I think that is something I would discuss with the patient.
So you might lean towards discussing adjuvant chemo, which feels a little retro these days, as opposed to an adjuvant IO. Now, Dr. Galsky, you had a major role in this trial. Do you want to have anything to add to that assessment, or would you have treated the patient differently, just without the cell-free DNA, just based on pathologic data?
Yeah, so I think we have to be careful about making major conclusions from hypothesis-generating underpowered subgroup analyses. If you look at the subgroup analysis for upper tract disease for the DFS endpoint in Checkmate 274, the effect size did seem to be less, but if you look at the overall survival subgroup analysis, that wasn't true. And so it just goes to show you, if you look at multiple subgroups, you can be misled. So I don't view that data as definitive for not recommending adjuvant immune checkpoint blockade for patients with upper tract disease.
So you think that would still be an option for this patient.
Absolutely.
And how do you think between, we have the POUT data, which looked at adjuvant platinum-based chemotherapy that was beneficial, and you have Checkmate 274 looking at adjuvant Nivo. How do you counsel a patient? And we're in an era where actually Gem-Cis Nivo is considered a standard perioperative regimen, technically neoadjuvant. Is there a role for giving platinum plus a PD-1 to someone if you think they're high risk, especially for upper tract, or do we not have enough data to kind of go there?
So we don't have data. The neoadjuvant data for platinum-based chemotherapy plus immune checkpoint blockade in upper tract disease, the path CR rate is fairly low, and so that does bring some pause to that general approach, but we don't have data in the adjuvant setting.
Okay. So now the patient got cell-free DNA, and they used the Signatera test, which is a bespoke assay. Tumor gets sequenced, probes are designed based on the identified mutations. Later on, they get blood drawn, and then the DNA, those specific mutations are looked for in the blood. And there's a lot of data that's been generated showing that this has a lot of prognostic importance. I'd love to ask maybe Dr. Necchi, I know in Italy you don't have as much access to this. Are you able to send an assay like Signatera, or is that harder for you in international?
Yeah, well, anytime I see discussing these opportunities, I remain frustrated by the fact that most of these opportunities are actually not available in most of the extra US countries. For example, just to make an example, Italy as an extra is a European country. We don't have access to Signatera test, even as an out-of-pocket test. There is no way of accessing the test outside of clinical trials or outside of research protocols. There is no way to access adjuvant nivolumab today. It's not reimbursed. So actually, it's a very theoretical discussion, And I suspect that for this patient population in particular, adjuvant nivolumab will never be a reality in this population. On the other side, we do have chemotherapy. In the POUT study, as Shilpa has mentioned, it's clearly indicated that there could be an opportunity also to spare most of the renal toxicity by using carboplatin. But my general feeling, my experience is negative towards the use of chemotherapy adjuvantly in this patient population for multiple reasons. And the vast majority, if not all the patients with this particular situation, will start the follow-up phase and strict surveillance instead of doing anything.
Dr. Gupta, do you think there's a role for ctDNA in this patient? Because obviously, Dr. Plimick ordered it and saw it was negative and then felt a little more comfortable recommending surveillance. How would you approach it?
Yeah, I think, we are all ordering ctDNA because unlike Italy, we do have the luxury to order it here. Although I think it's important to keep ordering it serially. And at this point, we don't have that data from upper tract disease. But I think it's reassuring that it's negative. To be honest, we're all doing it. But I'm personally not changing treatment if just ctDNA becomes positive and the scans are still negative.
So you'll still follow a patient. So maybe it's an early marker of disease recurrence, but you're not yet comfortable to actually give someone therapy based just on a biomarker like ctDNA. Matt, do we have good data about upper tract ctDNA and recurrences? Do you think that this is there a future for upper tract disease here with ctDNA?
So in IMvigor 10, which was the retrospective analysis of the adjuvant atezolizumab study, of course, that study did include patients with upper tract disease. And so there's upper tract data from that study. IMvigor 11, the prospective study, which I'll get into a little bit, didn't include patients with upper tract disease. So we have clinical validity data. We don't have clinical utility data.
And then in your practice, are you routinely getting ctDNA on a non-trial patient? If so, are you using the Signatera assay or a different one?
I'm routinely getting it. I'm routinely using Signatera just based on, again, both clinical validity and clinical utility data in urothelial cancer, where we have some data but not as expansive data for other assays at this time. And I would say a little bit flipped from some of the discussion. It's helpful to me in informing a decision if it's positive. If it's negative, it doesn't help me, and I'll go through the rationale as to why.
Okay, I think that'll be helpful. We'll look forward to that. So at the end of the day, Dr. Plimick sort of used it to give some reassurance. It sounds like you have a little more hesitancy about using that. Clearly, there's not a prospective validation of using it in that context. So, okay, I think we'll move on to the next discussion between Dr. Love and Dr. Puls.
Professor Pals evaluated a 77-year-old man who was status post-surgery for a clinically T3 muscle-invasive lesion.
He had a cystectomy, and he was shown to have that T3, N0, M0 cancer. It's a pure urothelial cancer. This individual turned out to be PD-L1 negative. We didn't have any ctDNA on him. And the question is, where are we with this patient right now? This is a patient from about 6 months ago, Neil. Would I have given this patient adjuvant nivolumab? I offered it to him because I think having some perioperative therapy is attractive. But in today's world, it would be EV Pembro. And then even if that EV Pembro data didn't exist, because of IMvigor11, I actually would rather do ctDNA analysis. And if they were positive, I would give them atezolizumab or nivolumab. And if they were negative, I would track their ctDNA. And if they became positive, I would give atezolizumab. So this is a field that's changed incredibly over the last 18 months. And it's a complete shift away from surgery and towards EV Pembro or circulating tumor DNA.
Okay, so there's actually a lot to unpack in this case. This is a 77-year-old man who has MIBC, poor renal function, so not a cisplatin candidate, who's PD-L1 negative. Now, PD-L1 is an interesting biomarker. In urothelial cancer, it's actually been quite controversial because with the exception of perhaps Checkmate 274, which we'll discuss, it really hasn't had significant value as a biomarker to tell us who to give therapy to. That said, and Dr. Necchi, please back me up here, in Europe, the approval for adjuvant nivolumab is based on a PD-L1 assay, correct?
Yes, the label is for PD-L1 positive tumors, yes.
So in this patient who has PD-L1 negative MIBC, it sounds like it might be hard to even give this. Would you give it, though, if you had the option to do it in PD-L1 negative, sort of ignoring the difference between U.S., where it's approved regardless of PD-L1 status, and in Europe? Or do you really agree with the European determination that this should only be for PD-L1 positive?
Well, difficult to say because it mostly depends on the patient commitment and the result for the decision where to do. What to do in this patient population is very, very highly dependent on the patient desire, on the patient willingness to and ability to follow surveillance, close surveillance, and how they perceive their risk in the time course post major surgery. So the decision should be very, very personalized. In patients who would like to get any kind of treatment to reduce as much as possible their risk to relapse, nivolumab adjuvant nivolumab is still an option, and the benefit in the PD-L1 positive patients, as we have seen within the latest update, is confirmed. So the magnitude of effect in PD-L1 positive patients is there. So the decision by the EMA to restrict the expenses to the PD-L1 positive patient is not something that is on the moon. Is actually a rational decision. But in this case, if he is strict, very willing, and very much committed to receive any kind of treatment, to play any card to reduce the risk of therapy, I would say yes. If he's skeptical about possible toxicity, or if he's totally free to accept the risk to relapse and being closely surveyed for the long run, I would be much more in favor of starting surveillance phase.
Okay, so maybe surveillance would be appropriate if the patient is going to have good follow-up, but perhaps if they really want to prevent recurrence, we might give it adjuvant nivolumab there. So here's a provocative question. I'm going to ask Dr. Gupta. We have perioperative data, a sandwich approach of EV and Pembro neoadjuvantly followed by adjuvantly, approved, as you just discussed, for patients who are cisplatin ineligible, and that's available today in the United States. So you say you have a patient who saw the urologist, went straight to surgery. would you offer them just the adjuvant portion of EVP? We don't have a study that specifically looks at that. How do you think about that?
I would not offer them EVP. But, if it's a patient who's cisplatin ineligible, very high risk, then it's a matter of time that if they recur, then EVP is the option. But I would not just offer EVP.
Yeah. Can you say more about why? Is it risk of toxicity, or is it just because we don't have the data, or is it kind of a mix of all of that?
I think, just based on lack of data as a purely adjuvant regimen.
Okay. Dr. Galsky, you're going to talk a lot about cell-free DNA in just a little bit. The IMvigor011 study was a major study presented just in October at ESMO, and this used cell-free DNA to help guide the decision to give adjuvant therapy. And I'll also point out that you're leading the modern study through the Alliance Cooperative Group, which is also a cell-free DNA or circulating tumor DNA guided study. So do you think that there's value in this patient? This is, again, NMIBC, trying to decide on adjuvant therapy. Do you think there's a role for cell-free DNA here?
I think there's a role if it's detectable, as mentioned before. If it's undetectable, I think that we have to be much more cautious. And again, I'll go through the data and point out why. But the study was designed to address a ctDNA positive question, not a negative question. Even though there's data, that's not the way that the study was designed.
Okay. So it sounds like more to come there. So, you've already said that you think using ctDNA positivity is really where we need to focus, not on ctDNA negativity. What's the value of the longitudinal monitoring, right? In some studies, we've only seen, for example, one post-operative assessment of ctDNA. In other studies, like IMvigor011, they followed patients for a year. Can you talk to that, explain that a little better?
Yes. So in a patient who has undetectable ctDNA, and I'll go through the study design from IMvigor11 and the data, but in patients with undetectable ctDNA, they had serial monitoring on IMvigor11 every 6 weeks initially for a year. And in patients who had detectable ctDNA, they could initiate immune checkpoint blockade at that time. So in a patient who the decision has been made to monitor, then absolutely, I think there's a role. This is a new clinical disease entity, molecular recurrence. Now we have prospective data that one can intervene on that clinical disease state in a meaningful way and impact outcomes. So now I think it should be done.
And I get this question a lot, and partly because the Natera company will actually contact the patient and say, how frequently do you want to get this test done? Sometimes the patient turns to me and they say, how frequently should we do it? Should we do it once a month, 6 weeks, every 3 months? What's your approach?
So we've been doing it every 3 months for the first year historically, and then the IMvigor11 data came out and it was every 6 weeks, and I think that's really where we have the data suggesting a benefit for intervention. It becomes a little bit more cumbersome to do it every 6 weeks when we're not seeing the patient, although there are home draws and things like that, so it can be done. And I think if you really follow the data, then following that schedule is probably the right thing to do.
Right. Do you think, just let's hypothesize for a second, do you think there's a difference, Dr. Gupta, between 6 weeks and 3 months of monitoring?
I think to Matt's point, and the 6 week is more attractive to me because then you can move up the scans. I've had a couple of patients who got their report before I did, and they sent me in basket that my ctDNA is positive. So I moved up the scan and I did find something. So I think doing it before like many weeks before you are supposed to do a scan kind of makes sense for the whole reason why we want to do it.
Right. For many of you who don't treat a lot of bladder cancer, I find there's a lot of parallels with PSA and prostate cancer, which is a biochemical test that strongly predicts recurrence. You can see it go up. I think it's harder to know what to do with that data as a predictive marker to tell us what therapy to give.
Subsequent to the recording of this program, the FDA approved durvalumab in combination with BCG for the treatment of adult patients with BCG-naive, high-risk, non-muscle-invasive bladder cancer. The FDA approved pembrolizumab in combination with enfortumab vedotin as neoadjuvant and adjuvant therapy for adults with muscle-invasive bladder cancer undergoing cystectomy. The FDA also approved adjuvant atezolizumab for adult patients with muscle-invasive bladder cancer with MRD-positive ctDNA after cystectomy. Please check out the official prescribing information for more. This concludes our program. Conflict of interest statements for the faculty can be found in the program notes. The use of agents and treatments that are not approved may be discussed, so check out the package inserts for more. Special thanks to the faculty, and thank you for tuning in. This is Dr. Neil Love for Second Opinion, integrating novel approaches into the management of non-muscle invasive and muscle-invasive bladder cancer.